All right, well, welcome everyone. So today we're going to do is just go through a lot of kind of newer things that are out there being used now. We'll talk about some of these are very new. Some of them have been around for a long time, and we just don't see them much in Maryland. And some of them have been around, and we are starting to see more of them in Maryland. So it's kind of a mix, but a lot of it is stuff that the majority of people who don't really work in the addiction field may not ever hear about. These are the learning objectives, so that you'll just know about some of these new things, and some of them are used as adulterants in what else is supposed to be out on the street, like heroin. Don't have any conflicts of interest. So just a little bit of background and some other terminology. So we talk about kind of newer drugs, sometimes that people use different terms. A popular one has been designer drugs, and that's an interesting, you see there, it started in 1988, and it was really at the time used to talk about specifically then fentanyl analogs that we'll talk more about, because that's obviously very relevant to what's going on in the world now. But really what it was intended to address is any substance, but we go back to the Controlled Substance Act in 1970, and that's really what established the DEA and the scheduling of drugs, making drugs quote unquote illegal. And up until then, there was no real way to kind of address drugs that were similar to other drugs. So back in 1986, the Controlled Substance Analogs Enforcement Act was put in place to try and somewhat at least address drugs that are similar to pre-existing drugs that are scheduled. So you hear that term a lot. Now there's a lot more this NPS, novel psychoactive substances, is a very common term being used, just synthetics. And then, club drugs was a period when a lot of the designer drugs were really associated with kind of nightclub, the rave scene back in the 80s and 90s into the 2000s. So as we talk about designer drugs, again, the idea that somebody's trying to make a new drug to get around the pre-existing laws, but a lot of what we talk about is actually, we'll talk about some examples, but many of them have actually been around for a long time, but they just become popular as drugs of abuse, and people think of them as these designer drugs. We'll see some of them are based on chemicals that are synthesized for legitimate reasons, but never really developed into medications. Some are just, they're marketed legitimately, but then diverted to illicit use. You see here others, like I said, they kind of get shelved, and then somebody digs up the recipe to make them. So there have been thousands of them made. And hundreds that have actually become, used out there, and then handfuls that we'll talk about some of the more popular ones. So other just some basic concepts, and again, I'm hoping people are aware, but nowadays it's really hard for people when they're buying drugs to know what they're getting. And often you're taking a history, somebody's presenting with symptoms that are consistent with one thing, and they're telling you they're using something else. So really important to realize that. And part of the issue is, a lot of drugs come in little baggies, whatever, but people press them into tablets. Kind of an old way was to just punch holes in a piece of plexiglass and you make little tablets, but kind of primitive. But nowadays, people can buy these sophisticated machines. This is a tablet press. This is a machine that actually fills capsules. So, not even the highest level drug dealers can get a hold of these machines and make really good counterfeit pills, which is a huge issue. Then there's also the source of drugs. So, obviously we have the kind of common street dealer, for, this, going back to the 1800s, a lot of, especially opioids that were being used came from physicians, but certainly with the prescription opioid epidemic, we saw where a lot of physicians, many were prescribing very well-meaning and appropriately, but there were also many that were, very unethically helping to get a lot of illicit opioids out there. But what's really been a big issue more recently is the dark web, which here at University of Maryland in Baltimore, West Baltimore, we don't see a lot of this, but certainly people could be practicing in areas and seeing higher socioeconomic level patients that are much more savvy with computers and getting on the dark web. And this is just an example from a popular one that was shut down for a while. There are versions of it back up, but you can go in there and order pretty much anything. So just the way drugs are distributed has really changed as well. And we're talking about common things, but I always love this story from Keith Richards that patients do lots of different things, or people do lots of different things. So we're going to talk about some of the more common. So first, we'll talk about designer opioids, given the epidemic now. So, there are other ones as well, but many of them are fentanyl analogs. So people talk about these non-pharmaceutical or NPFs. And here's just a list of some of them. There are even more than that. But for decades now, there have been a few that have been popular. So alpha-methylfentanyl, 3-methylfentanyl, carfentanil. Some of the original ones back in the 70s, 80s, it was called China White, this very pure looking, and often it was even then sold as heroin. Important to realize the purity of some of these is very, very high. And we'll talk a little bit about other ones, but here's one, again, with some historic interest. It was actually a meperidine or Demerol analog. So a little bit of history. The alpha methyl showed up in the 70s, and there were some deaths back then. TMF appeared in the 80s, and we'll talk a little bit more. Specifically in Baltimore, we had a mini outbreak of that. And then the one I mentioned, the one that's a Demerol analog, very interesting. Back in the 70s, there was a rash of young drug users who were becoming Parkinsonized. They were developing Parkinson's symptoms, and they kind of traced back, finding the dealers, that kind of thing, and found that the person who was making this drug was being sold. Part of the manufacturing process, he was making a chemical that was actually damaging the substantia nigra that's important with Parkinson's disease. So again, there's a lot going on now, but some of this has been going back to at least the 70s. Just showing you the outbreak that we had of the fentanyl here in 92. If people remember, we had another one back in 06, a much smaller, again, fentanyl outbreak, which interestingly, the way that they kind of found where that was coming from apparently started in Salisbury, where someone overdosed but didn't die, told the police who his dealer was. They found him. He gave up the dealer above him, and they kind of traced it all the way back to a lab in Mexico that was making much of the fentanyl that was causing that epidemic. But really, what's been going on now since around 2013 is the current, initially we started to see people buying heroin that had a little bit of fentanyl mixed in it. And over the last 7-8 years, it's really come to where almost all the heroin now has been replaced by fentanyl, certainly in certain areas, but certainly here in the Mid-Atlantic, we're one of the areas where this is the biggest problem. I mentioned carfentanil before, a very, very highly potent. It's actually used and medically approved as a large animal tranquilizer. And so as you can imagine, even a little bit of that in someone's, the quote unquote heroin supply can be lethal. And then there's some others that are not fentanyl analogs. So one that we hear about is pink, or sometimes pinky, or U4. This is kind of its name, U47700. So I mentioned this was actually developed, decades ago as an opioid, and then never really progressed to, becoming a medication. Kind of was shelved for a while, and then the last, 5 or so years, somebody found the the recipe how to make it and started putting it out there. Just showing you from one of the dark web. This is an ad where you can actually go in and order this. Another one, even newer, it's called ISO or isoniazid. It's actually not scheduled here in the US. It's, again, we just started seeing it in around the summer of 2019. Seems to be coming from China. There are pockets where it seems to be popular in the US, a lot more in the Midwest, but we're starting to see it on the East Coast as well. And again, this isn't a fentanyl analog, but it's something that no one would be testing for. So it's all a problem. And like 5-6 years ago, when the fentanyl started replacing the heroin, most places weren't testing for fentanyl then. And if their urine's coming back negative for opioids because there isn't heroin in there, and you're not testing for fentanyl, you don't know what's going on. Now with these newer non-fentanyl analogs out there, we're not testing for any of these. So it could be that as these become more prominent, we're testing for fentanyl and it's going to be coming back negative, and it's just going to be really hard to get a handle on it. Another one even newer is Brorphine. This is its scientific name here. It's been nicknamed purple heroin, which I'm not sure why it hasn't caught on here in Baltimore yet with the Ravens, but as far as we know, we aren't seeing it here in Baltimore yet, but it's popping up in kind of the Midwest. They're seeing a bigger problem with it now in New Orleans and more in the South. But again, it's not at all related to fentanyl. It's not tested for. You see much more potent than morphine. Starting to see fatalities that people are looking. There's some concern, again, this is new, so it hasn't been studied a lot yet, but there's some concern that it may actually, similar to what methadone can do, lead to torsades and arrhythmias like that. So again, just to be aware of this name, because it wouldn't be surprising if we start to see it more in the mid-Atlantic. So another term, as we're talking about opiates, this isn't new, but probably new to many people here, because if you've not heard of tar heroin or black tar or Mexican tar heroin, it's a less processed or a cruder form of heroin. And for the last few decades in the US, it's really been manufactured mostly in Mexico, comes across the land, and it goes west of the Mississippi. So much bigger issues with tar heroin in California, the Pacific Northwest, the Southwest. But for the last decade or so, it's been creeping as the Mexican cartels have taken over in Appalachia and New England and other areas, starting to see tar much more in those areas. We really don't see it much on the East Coast yet, but we're starting to see it even like in West Virginia, again, places in Appalachia, and certainly like I do Suboxone by telemedicine with programs in Hagerstown and Frederick, and even there, I'm starting to see people that have either tried or know people who have found tar heroin. So again, it seems that it may be coming even further east. So just to be aware. So what to know about tar, it's what it sounds like. It's kind of gummy. You see here it's wrapped in cellophane or in tinfoil because it's got a gummy, sticky consistency, and it's typically used by smoking, or you can inject it as well. But the typical is it's called chasing the dragon or foiling. So you put a little piece of this tar on a piece of tinfoil, put flame under it. As it vaporizes, you use a straw to breathe in the vapor. So again, something that we really just don't see around here, but it does seem to be getting closer. Just just so you know, there's some other things associated with this, a leukoencephalopathy that some people think actually is chemicals coming off the tinfoil. And then sometimes people do try and take the tar and dissolve it in water and inject it, which you can imagine is even worse than injecting powder. And also you can have things like botulinum and other things that live in moist environments in there. So again, if we start seeing this on the East Coast, it brings, the one good thing about it is smoking, like places at sea smoking have less injecting. And so less HIV, hepatitis C from that, but then you can get even different problems from injecting the tar. Some other opioids just to talk about. This is something I've heard people talking about recently, and actually it's funny. So Krokodil is a Russian rough translation for crocodile. But actually, had a resident the other day asked me, she kind of knew what she's talking about, but she asked me about that drug called alligator. So she mixed it up a little bit, um, but Krokodil is something that really it's the true Krokodil is desomorphine, which can be synthesized from codeine. Um, Became popular in Russia back in the earlier 2000s, and developed into a pretty big problem there by the late 2000s. And then around the early 2000 teens, we started hearing about it, some in Europe, but a little bit here in the United States. And um, it's not really clear how much is truly the crocodile, which is the codeine that's processed into desomorphine. And places that might have it are places where there are actually more, Russian mobs involved with drugs. We don't, really have that here in Baltimore, but there does seem to be some places. But what really, the big issues with crocodile is that it seems to lead to really bad abscesses, and you see here just really, terrible skin infections. And some of the hospitals around Baltimore have been noticing more of these. And so there's been some discussion, could we have crocodile here? We probably don't have the true Russian crocodile, but it might be because people think that the skin issues come not necessarily from the drug itself, but from the process, which uses solvents like kerosene and gasoline and phosphorus. So it could be that there are some people now that are making, putting opioids out on the street that are processed in a similar way. Another, opioid that you may have heard of is kratom. We won't spend a lot of time on this. It could be a whole talk in and of itself, but lots of different nicknames for it. This is some I've just saw recently, this 4x100 with kratom, Coca-Cola, cough syrup with codeine and on ice. But this is a plant that found in Thailand, Malaysia, Indonesia, and used sort of like cocaine is used in the Peruvian mountains, that people use it and just put the leaves in their mouth that absorb slowly and helps them with energy. Sort of similar use in some of these areas, but it's really been used for an opium substitute, and even as back in the 1800s, people were using it to help manage opioid withdrawal. It's become popular in parts of the U.S., real popular out in Pacific Northwest, San Francisco. There are now stores around here, a lot in D.C. that are selling it. It's a very interesting chemical and needs to be studied more, but seems to have some hallucinogen properties like psilocybin, magic mushrooms, but it also does seem to have effects on the various opioid receptors, including some effects on mu opioid receptors. Just very interesting. We don't see the typical mu opioid overdose with it, but people who do take it chronically can have very similar mu opioid withdrawal symptoms to like other opioids. And it's got an interesting legal story, certainly in other places, but here in the US, the DEA back in 2016 tried to emergently, make it Schedule 1. And there were actually a bunch of, people who pressured their legislators to not allow the DEA to do that. So actually they didn't proceed with emergently scheduling it, and it was put out for public comment, and still it's not a Schedule 1 drug here in the US, so you can go and buy it. Another hot substance that people have been talking about is xylazine. So xylazine is an alpha-2 agonist, kind of like clonidine. It's very similar structurally to some of the older antipsychotics and atypical antidepressants. And it's used in the US, it's actually approved for veterinarian use only for animals. And it's kind of funny, they actually specify the animals it's approved for. And these are just some of its names for the veterinarian products. But again, similar to clonidine, but you can get really significant sedation, hypotension, slowered heart rate. It has some effect actually on blood glucose as well. There have been a few reports of skin ulcerations and abscesses. And so again, as we've been seeing, we think more of these here in the Baltimore area and other parts of Maryland. There's some concern, could this be it? But again, the reports that have discussed it, many of them, it wasn't even confirmed that xylazine was in what they were using. It's certainly not described in the veterinary literature. So again, it's really unclear, but we're definitely starting to see more of it. It's been, like little outbreaks of it in the illicit market since the 70s, but really started to see more in Puerto Rico back in the early 2000s, where it was being cut with the heroin. We're starting to see it more and more in the US. We were seeing more in the Mid-Atlantic, and the last couple years seeing it here in Maryland in different areas. So again, it's people don't know it's cut in with what they are buying as heroin or fentanyl. Just some of the kind of slang terms for it, and this is a new term we're hearing about now with fentanyl, cocaine, and xylazine called wipeout. Another thing to be aware of is tianeptine, which is actually an atypical antidepressant, which is available in much of Europe and Asia, not here in the US. But usually when people are getting it here, they're buying it through the dark web. Hearing about misuse since the early 2000s, but a lot more in just the last few years. And it's a very interesting medication because it has some effect on serotonin like SSRIs, but seems to have some effect on mu and delta opioid receptors as well as glutamate receptors. So again, I've not heard of this very much here in the Mid-Atlantic, but there's certainly pockets where it's happening. And it does seem to be increasing, in the US. So something to be aware of that we may start seeing more here in Baltimore. I put in here about designer benzos, and they're not really designer. The vast majority of these are actually benzos in other countries that are just not available here in the US. But a huge issue, and I just put some examples up here, but really a growing number through the 2000 teens of these that are showing up, and many of these are in Asia and Europe. And again, people are buying them through the dark web and using them and reselling them here in the US. So yeah, they're all benzos, so there's nothing really unique about it, but again, they're people that are now trying to find these different benzodiazepines, which are just not available here in the US. So now a little bit about kind of the class of drugs that MDMA or Molly or ecstasy is in. So they're generally, people talk about them being psychedelic stimulants because they have properties of both psychedelics or hallucinogens, with actions at the serotonin system, and stimulants with actions at the dopamine and catecholamine system. There have been thousands of them synthesized over the years. And I just put this up here, the Shulgins, if people are interested. They were a couple that, synthesized many of these, decades ago and, published books about, have the whole following of people, with these psychedelic stimulants. But and again, there have been thousands of them synthesized, but a handful that have become popular, and MDMA we'll talk a little bit more about. And then just some of the other names that you'll hear, some of these 2CBs, Nexus is popular in Minorex. So again, we don't see these other ones as much around here, but again, a lot of these coming off the dark web, some of them popular in the more kind of the jam band and electronic music world. So if you see, again, patients more from that area, you may hear about that. But just, MDMA is kind of the prototypical designer drug, which again was synthesized back in 1912, so was not actually made to get around designer drug laws, but again has a very long history that we won't go into. But they were really the ones that in 1985 led to that analog law being passed, because back in 1985, MDA, which was already a Schedule I drug, there was more research coming out that it was causing brain damage, things like that. So people were concerned that MDMA was very similar to MDA, and so that's when the DEA emergently scheduled MDMA as a Schedule I drug, and that led to the making that analog law to try and address these things that were similar to other drugs. So if people weren't aware, real significant use in the late 90s to the mid 2000s. Alzheimer's was real big in the rave scene, and became just a big issue because it was really affecting, unfortunately, kind of like the opioid epidemic. Once it really started affecting the suburban middle class kids, people started paying more attention to it. But it kind of died off in the late 2000s because it was, so much of what was being sold was adulterated and often didn't have any MDMA in it. And then around 2012, it was kind of rebranded as Molly, or people say molecular E or ecstasy. And it's still popular now. We used to be much more in the suburbs, and that now we see here in Baltimore City, pretty popular still, Molly, and I know other areas. So just to be aware. And if you're not aware, it's also being studied for PTSD and depression. And there are actually now been a few studies of it for PTSD, and there's talk of trying to go for an FDA indication for that. So back in the late 80s, 90s, early 2000s, ecstasy was these really cool little tablets with insignia stamped on them. And then to try and get away from that, the more recent Molly is much more often like looks more like a drug or a medication to try and get around that, what had become where it was adulterated. But really what's happened now is, again, much of when people are buying Molly, a lot of it doesn't have MDMA in it anymore. And it's just some examples of places where, bad things have happened where, people thought they were using Molly. A lot of it now being adulterated with some of the pure synthetic stimulants that we'll talk about in a few minutes. Others of these methylated things, this one you hear Smiles. And again, there are hundreds of these drugs out there. This is another one that the Shulgins made. But these have to do with their chemical structure and all, but not to remember all the details, but just to be aware of, there are a lot of these things out there. Different groups are using these. Again, you can get these off the dark web. A lot of younger people, again, people who are much more savvy with the computer getting these, but pretty similar in their being like MDMA. Another one, N-bomb. that you hear about. Um, Again, similar to the other. This one I like, Bromo Dragonfly, and it gets the name because some people think the chemical structure looks like a dragonfly with the wings and all. Um, Again, working kind of at serotonin and dopamine systems. But this one, reports of vasoconstriction, seizures, and so some of these again they're not benign things. Again, not something that we see a lot of. Not aware that we're seeing much here in Maryland right now, but just things that are out there. And again, different groups are using some of these things. Another group called piperazines that are based on the antihelminthics. So again, just some examples of some of these. People talk about this as kind of the more popular one called benzofury. Sounds like it would be related to a benzodiazepine, but it's not. So these are also an interesting group of medications. They, again, have hallucinogenic and stimulant effects. Um, this has also been reported with seizures, possibly QT prolongation, and many of these, because of their effects on serotonin, you can get a serotonin syndrome as well. So another one people may have heard of before, DMT is a synthetic drug, 5-methoxy DMT. Here's its chemical. People may have heard of, people licking toads to get intoxicated from that. They're usually talking about these Bufo various toads that secrete this 5-methoxy DMT. And it's, a very strong hallucinogen. So again, we don't hear about this a lot in inner city Baltimore, but there are areas where people are getting this 5-methoxy DMT on the internet. Ketamine, we won't spend a lot of time. It's not new, obviously, but again, one of the kind of classic club drugs that was real popular in the 90s, early 2000s with ecstasy. But it is becoming more of an issue now that it's being used for treatment-resistant depression, used much more, used to be just like in the OR. Now it's used much more in, EDs, even some EMTs are using it. So more of it is getting out on the streets. So just to be aware that we're seeing more ketamine being misused. If you're not familiar with it, it's kind of like PCP. It's a dissociative anesthetic, works primarily on the glutamate receptors. It has activity at some of the other ones as well. And again, even though people talk about it as a designer drug, it was first synthesized back in the 60s and has been used medically since then. A lot of it in veterinary medicine, but again, growing in human medicine. Um, but it's really been misused since, soon after it came out in the 60s. And then if you've not heard, there's a newer, it's been around for about 10 years in Europe. We're starting to see it here in the US though. So it's actually a ketamine analog called methoxetamine. And these are some of what packaging looks like. Again, a lot of this people are getting on the dark web. Um, Again, so fairly similar to ketamine itself. Effects primarily on glutamate receptors. So again, just to be aware, and you've heard it, and if we start seeing more of it, you'll at least know what that is. So I mentioned before when we were talking about some of the Molly that now is really being adulterated with other synthetic stimulants. So, synthetic stimulants have been around for decades as well. Many of them it's, different than amphetamines. It's a different class of stimulant called cathinones. The kind of classic ones are this one, MDPV and mephedrone. So we really started to see this in around 2008. And if people remember bath salts, that's what the bath salts were, these different synthetic stimulants, primarily these ones. Um, they really kind of, started in the late 2000s and really kind of peaked in the early 2000 teens and have sort of trailed off, unlike the synthetic cannabinoids that we'll talk about. So we don't hear that much anymore about the bath salts themselves. But just to be aware, they're fairly similar to cocaine, with effects on dopamine and norepinephrine reuptake blockade. Um, just to show a little bit, and we'll talk about the synthetic cannabinoids in a minute, but when both of this synthetic cannabinoids and the bath salts were a real big problem in the early 2000 teens, this is when a law was passed that made a handful of both of those two groups of substances illegal. We'll talk more about that. This is another one of them. I don't know if people remember Flacca. That was a big internet thing about, some guy who was eating somebody's face. And so again, it's just a different one of these synthetic stimulants, similar to that MTBV that I mentioned. See a lot more of this in the South. But again, this will pop up. And what was starting to happen is a lot of what people were buying as Molly, when it was actually analyzed, it had more of these things in it. And so people were just getting, with all stimulants, people can get, psychotic and people describing this excited delirium. And then a newer one, which we just started seeing recently, is called Eutalone, which is another cathinone. It seems to be replacing some of the other ones. And we're starting to see this actually specifically here in parts of Maryland. Um, and where we've been seeing this is if people have heard of trash can. So this is actually, a report from this is the DA's HIDA, the high intensity drug trafficking, for this area. So back in 2019, we started seeing these little, and I don't know if you can appreciate, they're like little, I have a few of them here actually. I don't know, well, you can see them on my camera, but they're these little, plastic cylinders with a hinged lid, like a trash can, that we started seeing around 2019. Um, Different areas. We see them certainly here in Baltimore City, but a lot of these other areas in the state have been seeing them. Sometimes patients will actually just say they're using trash can, like it's like that's the drug. But when they have confiscated some of these and tested them, all these things have been found in them. But again, when you ask patients about them, a lot of them talk about the synthetic stimulants like the Eutalone. So again, they're not real common. It's not even clear why, is it certain drug cartels that are using them? What's the advantage over this over the little baggie? I'd like to think it's a green cartel that's trying to use recyclable plastic rather than the plastic bags, but no one really knows why these little tiny trash cans are out there, but we're certainly seeing them more. So something again, ask patients about, but even then you really don't know what it is. It's been found to have the heroin and fentanyl, but a year and a half ago, there was a report that, it's described here, but up at Union Memorial Hospital, they had some patients and kind of describing them like this Flacca picture, very kind of agitated, delirious, psychotic. And so again, if you hear about that, it's worth asking. It may be that it has Eutalone or another one of these synthetic stimulants in it. Methamphetamine, again, not at all new, and I'm not going to spend a lot of time on this, but just bringing it up because, traditionally we have just not seen a lot of methamphetamine, certainly here in Baltimore, but really, in Maryland as a whole, compared to the West Coast and the Midwest. But we are definitely starting to see more of it, and especially in, again, not, we see some of it in the city, but much more of it in, Western Maryland, where it's closer to Appalachia, where it's much more popular. The Eastern Shore, Southern, and a lot of, like, when I see patients by telemedicine on the Eastern Shore in Southern Maryland, they talk about actually going to Virginia because it's much more popular there. And then Northeast, like Cecil and some of the northern Eastern Shore, because it's much more popular even in Delaware and New Jersey and Pennsylvania. So just to be aware of methamphetamine, even though that's been around for a long time, not something we see a lot here, but it does seem to be really growing in Maryland. Then we'll finish up with the synthetic cannabinoids. Again, they're not new. They've, again, I talked about a lot of these were actually developed back in the 80s when we really just started figuring out about our endogenous cannabinoid system. People started making medications that would work there and thinking it might help with appetite and things like that. So there were a whole bunch of these chemicals that were, synthesized back then and just kind of shelved. And in the mid 2000s, initially in Europe, and then around 2006 here in the US, people started putting these out as initially spice and K2. So again, just they've been around here now for about 15 years. They really kind of peaked in the early mid teens, but there's still a lot around here still. If you're not familiar with them, they're you smoke it the same way as marijuana, but different than that, it's a synthetic cannabinoid. So the plant material that somebody smokes is just dried up leaves and twigs and stuff, and then they spray the chemical on it. Market is incense or aromatic potpourri, so that the FDA doesn't have jurisdiction over it. And we won't go into a lot of the pharmacology, but the important thing is that people don't realize, but THC is actually only a partial agonist at our cannabinoid receptors, whereas these different synthetic cannabinoids are full agonists. So they tend to, have much stronger binding than THC, and can lead to, a lot of different effects because of that. There are dozens and dozens of these out there. And so it's hard to even categorize them because some of them are very similar to each other and some of them aren't. Some of them can cause seizures, which is something you wouldn't see with marijuana itself. Seems to be able to cause psychosis much more easily than marijuana does. And then some people, when they get psychotic, stay psychotic longer than with marijuana. And I mentioned before the law back in 2011 and 12 that made a bunch of these illegal. This is just showing them. And so again, there were like 20 some of them that were made illegal. But the problem is this really is kind of like designer drugs that, I'll show these in a minute, but there's some now that are coming out that are really not even that similar to the other ones. So truly designer kind of getting around very different things. Some of the more common ones, if you order, a cannabinoid or a synthetic cannabinoid panel, the big drug testing labs can test for them, but a lot of these newer things are not even testing for. Just show you some of these. These are the little foil packets that they come in. Again, they're all like incense or potpourri. And then just showing, back in 2012, because prior to 2012, they were all legal. And then so once that law was passed, they then like started labeling that they didn't contain the ones that were illegal. So they're technically legal still. And then, just kind of going back to the picture of Santa Claus in the beginning, if people remember a few years ago, we had an outbreak, and it was other parts of the country as well, but we had a few cases here where people were smoking, what they thought was K2 spice, but were developing bleeding disorders. And so even things like, something like this, can be adulterated and, have significant problems associated with that adulteration. So it's again, just kind of reiterating how important it is to talk to your patients about the stuff out there now. It's just so hard to know what's really in it. And I just put in this last one again. This isn't new. It's been around for a little while, but it has periods where it becomes more and less um, popular. But if people have not heard of salvia, it's a very unique hallucinogen that not even really sure how it works. It doesn't work kind of the way that the more traditional ones do on largely the serotonin system. Um, some of the street names for it. And it's something that, again, the DEA has tried to find a way to schedule it, but it's just chemically not similar enough to LSD or any other classic. And there just isn't enough research to show that, how dangerous it is. And there are other hallucinogens like this we just don't have time to go into, but this is another one that again tends to be younger people. It's legal, so you can get it sometimes in just like head shop kind of places, but a lot of people get it online as well. And it's really interesting to go online and read accounts of it, and people really talk about it being this very unique hallucinogen. So again, just to be aware of if you hear people talking about salvia. All right, so yeah, I know I went through a lot of things, and I think you guys can get copies of these slides, and I think again a lot of these, like I said, some of them are new everywhere. Some of them have been around and popular in other parts of the country, but we're starting to see more here on the East. And some of them are really just things that have been around and there are groups using them. We know that they are growing in the US. You may or may not ever see someone, but hopefully just having heard them, you'll think, oh yeah, he mentioned that, and you can go look it up again. So, but again, you'll have the slides. You can at least reference those. But I'm sure there are people have questions about other things they might have heard people using, whatever. So I don't know if it's best to do the chat or if people want to unmute and talk.
Hi, Dr. Welsh. We did get a couple of written in questions, and the first one comes from Thomas, and Thomas asks, is ketamine approved to treat chronic depression?
So yeah, ketamine or esketamine, the nasal spray is approved for treatment-resistant depression. So it's something it's done, so that you don't, it's not like the patient goes and picks it up at the pharmacy and it's a little nasal spray thing, but it's not like the patient can go get it. So it has to be done in in an office and under the physician's guidance. But yeah, it's been approved for a few years now to treat depression.
Great, thank you. This next question is a lengthy one, and this one comes from David Myers. And David asks, so what questions should we be asking when taking someone's EHR and their patient history? What would you suggest as an ideal format in the EHR to ask about drugs of abuse or drug use disorder? Recently, in the course of an ER visit, a nurse asked me, do you use any drugs? I responded, do you mean street drugs? Does CBD count as a street drug? And then hallucinogenics like psilocybin for depression, she wasn't sure.
Yeah, that's it's a complicated question. Even, I don't know if you remember, but back in there, I had the terms heroinil and phentoine, like combining heroin and fentanyl. It's gotten really hard to even know what, so like now that virtually none of what's on the streets here in Baltimore has heroin in it, and it's all different analogs, yet the patient is somebody that for decades used heroin. So, what do they now have a fentanyl use disorder, not a heroin use disorder? And then is that different than the person who purposely seeks out, prescription fentanyl to abuse that? To me, that's more of a true fentanyl use disorder. But the person who, yeah, they used to use heroin, but it's not there, nothing they can do about it. But now they're using fentanyl and fentanyl analogs. So even what to call it, a lot of people just started calling everything opioid use disorder, which is, more correct. So you're not, since often you don't even know what the person was really using, but as we start trying to get kind of more specificity as what's being used, if everyone now is just opioid use disorder, that's going to make it harder to kind of really tell what's going on through the diagnostic codes. But similarly, if we call the person who seeks out prescription fentanyl and the person who's trying to buy heroin, but they're getting, street synthetic fentanyls, if that's both fentanyl use disorder, that's also kind of hard to use to kind of really look at trends. So it's gotten really hard, as somebody's mentioning. There's a lot of research I mentioned with MDMA. Also a lot of research, a lot of it across town at Hopkins with psilocybin for, they're looking at everything from depression, end of life, kind of coping with, people dying from cancer, PTSD. There have actually been small studies for opioid use disorder, tobacco use disorder. There, if people have heard, there are a couple cities specifically, and then Oregon and other states are trying to decriminalize, mushrooms or psilocybin the same way states are decriminalizing marijuana. If people are using it kind of in to manage depression and things like that. So yeah, it's getting a lot messier, kind of with different substances that are being used now in different ways. Some people say don't, to try and use terminology kind of more precisely. So don't talk about illegal drugs, don't talk about street drugs. It's sometimes that, kind of makes sense. And if you talk about illegal drugs, like people may not want to talk about it because of your having labeled it that way. But yeah, it's hard to know now. There's just so much out there going on. But I just usually ask patients what else they're using. Now I ask them more about, do they, I think most people now know that very little of what they're buying is actually heroin. And but yeah, again, they still don't know. But just try and ask them more about, do you notice any difference in the feeling that you're getting from what you're using now compared to what you used to use? Really, I talked about the adulteration of the the spice K2, but didn't mention that seeing a lot now of like cocaine and marijuana being adulterated with fentanyl, and people having opioid overdoses from smoking marijuana and cocaine. So again, ask people what they use, but more now than ever in the past, I think patients don't know what they're buying. People don't know what they're buying when they're buying drugs. People think they're buying online, like real, oxycodone pills. They think it's safe because they're buying the real pills, and they're adulterated. It's not uncommon for an opioid to be adulterated with a benzo, which, significantly raises the risk of respiratory suppression and fatal overdose. So again, asking people, but just understand that they really don't know what they're buying anymore. I find that the terms and the words you use, they matter some, but much more important is the manner in which you're asking. And if you come across it at all judgmental, that's really going to affect how someone's going to answer you. So I think just asking in a broad way, but asking in a very, non-judgmental way is much more important than the actual words that you use.
Thank you, Dr. Welsh. We do have a couple more questions. This next question is actually coming from one of our DAX consultants. So that's from our District Addiction Consultation Service. And That's Dr. Salwan, and Dr. Salwan asks, can we get some of Dr. Welsh's expertise on treatment implications with novel opioids, in particular xylazine? And I apologize if I didn't pronounce that correctly.
Okay. Well, so xylazine is not a novel opioid. It's it's I mentioned like clonidine, but it's being cut in with the heroin fentanyl that's being sold. So, I mean, no one really knows because most places aren't testing for it, so you don't even know it's there. There's some people that think that the fact that now when we're trying to start people, say, on buprenorphine, it seems to be easier to cause precipitated withdrawal. And we've been attributing that to the fentanyl, which is, more fat stored, and maybe some of the fentanyl analogs have active metabolites that are hanging around. But there are also some people that are talking about that possibly it could be that some of this withdrawal is also made worse when someone has also been using the xylazine with their fentanyl. And as you're trying to manage their withdrawal, you're not attending to that. And so the coming out of that, because people, like same with clonidine, that can lower somebody's blood pressure. So if you stop it, suddenly somebody can get a rebound hypertension. And so yeah, I mean, it's something I think we need to be looking more at, but if we think that a lot of what's out there has xylazine in it, it could be doing the same thing. And then, we're managing with buprenorphine and the typical opioid withdrawal medications, but some of this could be the rebound that we see when somebody like takes clonidine chronically and stops it suddenly. So, no one's really been looking at that, but it might be that adding some clonidine might help with that kind of specifically.
Great, thank you. And the last question I'm seeing here is, which specific substances are medical professionals referring to when they diagnose patients with psychoactive substance use? And why are they using such a broad term?
Yeah, so psychoactive substance use could be literally any drug or any substance use disorder in the DSM. So you're right, it's not very useful for somebody to use that term. DSM would they break the drugs down into the kind of groupings, opioids, stimulants, hallucinogens. But really, if you're writing out the drug or finding it like in your EMR, they really want you to pick the specific drug, which specific opioid, which specific benzodiazepine, which specific hallucinogen. So as best you can, you like to be as specific as you can, but yeah, using the term psychoactive substance um, doesn't really help know anything more than that.
Great, thank you. That was our last question for today. I know that we are out of time, so I do just want to let people know that to receive your CME, CEU, or CPE certificate, please be sure to fill out the evaluation that pops up in WebEx. You will also be receiving the slides as well as other resources via email immediately following today's presentation. And I am going to turn it over to Julie just to give us one more overview of Max and to discuss staying on to get waived.
Thank you, Bridget. And thank you all again so much for joining us today.
Can I unshare, Julie? Are you going to show something?
No, that's okay. This slide that you have up is perfect. So just for anyone who is new to Max, we are a free service. We are statewide, and you can call us with any questions that you have about treating your patients with substance use disorders and chronic pain management. So we have our phone consultation line, which is the phone number in the bottom left of the screen. You can call for clinical questions or really any questions that you have about implementing or expanding office-based addiction treatment services. And as Bridget had mentioned, I know we have a good amount of prescribers on our webinar today, so if anyone is interested in applying for their waiver, please feel free to stay on. I do ask that you put your name into the chat to indicate that you are interested in this. And for anyone who's not familiar, there were new HHS guidelines that were released recently that made applying for the waiver a lot easier if you're only looking to prescribe to up to 30 patients. This process only takes about 15 minutes to walk through applying, and you will need your DEA number and state medical license number. Again, if you are interested in applying for this, please indicate in the chat.